We still have a pod and a keynote address this afternoon. So we still got a little bit. And then as you see, we have the RheumNow distilled, which means liquor. So 6 o'clock, we'll be outside, just outside here. It looks like it's going to be a beautiful evening, so that'll be good. So let's go ahead and jump back in. Got a great session. This is from Rheumatoid Arthritis Pod. I'm talking about decisive therapies. Jack picked that. I'm not sure what indecisive therapies are. Was that what we were talking about the whole rest of the day? So anyway, very pleased to start it out with an important topic near and dear to all of us in rheumatology. That is methotrexate, and no one better to do that than Professor Joel Kremer, who was, like the country song says, he was methotrexate before methotrexate was cool. So he's going to give us a perspective that I think only Joel can give. Joel, welcome.
Thanks, Hardy. So I don't have much time, and I have a lot of slides. So we're going to go fast. And I don't like when speakers speak really fast, so I'm going to try to summarize some of my slides. And hopefully we can get something out of it. No conflicts. We've been studying methotrexate forever. The oncologists, before we even started methotrexate, said it was the best studied drug the world has ever seen. And we've contributed another 10,000 studies. We should know what we're doing with this drug. Controlled studies on everything, by itself, with the addition of other DMARDs, with biologic DMARDs, with everything on that slide. And it's become our anchor drug. So I did a bunch of long-term studies. I did a bunch of other studies with methotrexate. As I say, we have studied this drug, so we should know what we're doing. And I'm moving along, as you can see. Methotrexate and biologics. Most biologics work better with methotrexate, and there's a variety of reasons for that. There's only one biologic, tocilizumab, in which people have attempted to taper methotrexate successfully, but you have to be careful. Triple therapy. Raise your hands if you use a lot of triple therapy. Okay, I see a few hands. We did, with a denominator of 50,000, we did a survey and we found 300 patients on triple therapy. And of the 300, 150 had deseated, mostly because of sulfasalazine. I'll have a little bit more to say about that. But you can combine methotrexate with a bunch of things. Quiz question. I thought this was going to come later. All right. How would you treat a patient with methotrexate who was on methotrexate 17.5 milligrams weekly with an inadequate response? Add a DMARD, DC methotrexate, and start a biologic or targeted DMARD. Switch to split dose methotrexate, switch to sub-Q methotrexate. Both C and D are correct. Yeah, good. Both C and D are correct, and we'll talk about that. Oh, I just used up half my time. This is a slide that I have several times in this talk. And what it shows is when you use methotrexate orally or sub-Q, it peaks within hours. By 24 hours, it should be below 0.05 micromolar, which is basically unmeasurable. If the level of methotrexate is sustained beyond that level, you're in trouble. And we'll talk about it. I want you to know all this biochemistry, but let's go over it quickly. Reduced folate carrier actively takes up methotrexate as well as leucovorin, folinic acid. Once in this cell, methotrexate is polyglutamated with FPGS, and it's the polyglutamate form of methotrexate which is retained long-term. And methotrexate is essentially a prodrug. It is this form of methotrexate which inhibits target enzymes. Why is it important to know about polyglutamates? Because they accumulate slowly and they dissipate slowly, and it's only the polyglutamate level which gives you a therapeutic or a toxic response. Here is a cartoon of addition of polyglutamate moieties to methotrexate. This occurs over about 6 months to reach steady state, as we will see. So here is inhibition of thymidylate synthase, agar transformylase, methotrexate, the prodrug, methotrexate polyglutamate. 92-fold the polyglutamate, greater inhibition of the target enzyme with the polyglutamate form, 238-fold with the polyglutamate form here. So don't think of methotrexate as anything but a prodrug. It's a prodrug. The median time, and Linda Dalrymple showed this, the steady state methotrexate accumulation was about 6 months. The predominant species was PG3, 3-glutamic acid moieties. So what does that mean? You have a patient on methotrexate for a month, or 6 weeks, let's say, who's on 17.5 milligrams. You want to get them to a therapeutic value, and we'll talk about it. Do you wait 6 months for the methotrexate polyglutamates to reach steady state? Well, if methotrexate was the only drug you had, you would wait 6 months, because that's how long it takes to reach steady state. However, we're all impatient. And I only got 25 minutes for that. We're all impatient. And the idea is, let's get methotrexate to what is probably a changing level of methotrexate and intracellular polyglutamates that gives us what should be a therapeutic value. We don't wait for the full effect. This is what I observed when we published long-term effects of methotrexate. This is time in months, prospectively captured, and it so happens that you start to see a plateau at 6 months. This was only methotrexate, corresponding with the polyglutamate story. Not only that, when you stop the drug, which we're now doing for short periods, it takes about 4 weeks for the elimination half-life of the methotrexate polyglutamates. So the time course of methotrexate accumulation and decrease corresponds with the previously reported time course of methotrexate efficacy. Methotrexate is such an interesting drug. If you use it with a drug like infliximab, it will inhibit anti-chimeric antibodies. In fact, you can measure the level of methotrexate in RBCs. It's called RBC methotrexate polyglutamates. The higher the level of methotrexate RBC polyglutamates, the lower the level of HOC is, the greater the therapeutic value of the infliximab. So we're giving vaccines, and we're holding methotrexate now for 2 weeks. Why? Because when you give a vaccine, obviously you're giving it parenterally. It's a neoantigen. And methotrexate will prevent an adequate therapeutic humoral response to the neoantigen. So hold it for 2 weeks. Is 2 weeks magic? I don't know. Nobody knows. Could be a week. But don't hold it for a month because of what we saw, how quickly the polyglutamates are lost. 4 weeks. Methotrexate and pegloticase. I can never give pegloticase because there are always antibodies. But again, give methotrexate with pegloticase, and you inhibit the antibodies to pegloticase, similar to the way it works with infliximab. What about using methotrexate with other CSDMRs? I'm not going to talk about cyclosporin. Hydroxychloroquine, I always use Plaquenil. Hydroxychloroquine with methotrexate. I love the drug independently, but what happens is hydroxychloroquine, independent of its therapeutic value, will increase the AUC of methotrexate. It also inhibits the conversion of methotrexate to 7-hydroxymethotrexate. So you get increased levels of therapeutic methotrexate when it's given with hydroxychloroquine. Sulfasalazine, one of the reasons I asked about triple therapy. If you give sulfasalazine with methotrexate, 2 antifoals should really work. However, sulfasalazine inhibits the uptake of methotrexate at the RFC, at the reduced folate carrier. Radiografts are improved with methotrexate, not nearly to the extent of biologic agents. Why do we use methotrexate weekly? Why not Monday and Thursday? Why not? Why weekly? What is that? Is that dogma? Well, it turns out that rapidly dividing cells in the oral and gut mucosa, when exposed frequently to a dose of methotrexate that inhibits their replication, you will cause toxicity. So we give it so we can avoid those nuisance, and very often more than nuisance toxicities in rapidly dividing cells. Remember this slide? So if we were to do this twice a week, all the rapidly dividing cells in this AUC in the mouth, the gut, the bone marrow would be severely impacted. What determines methotrexate toxicity? If the tail of this again goes out beyond 0.05 micromolar, you're in trouble. Anything that prolongs the terminal half-life of methotrexate will give you that trouble. So what prolongs the half-life of methotrexate? It's 100% excreted via the kidneys. So any renal impairment, whether it be prerenal azotemia with CHF, dehydration, or even change of NSAIDs, has been associated with methotrexate toxicity. Oral versus sub-Q. We found in a study we did way back that if you study oral and sub-Q methotrexate baseline, and then you do it again at 6 months, and you increase the dose to 15 to 20 milligrams and compare oral with sub-Q, that the bioavailability, the ratio of what's absorbed orally to what's absorbed parenterally, decreases by 30% when you get to 15 milligrams. So that's a problem. You could be giving someone 20 milligrams orally in a single dose. They may be seeing 14 or 15 milligrams equivalent of methotrexate. Here's a study done by Johann Braun, and he double-blind, he gave patients who were randomized sub-Q versus oral methotrexate. Sub-Qs did better. They got full bioavailability. These are enzymes which are targeted by folate antagonists. They are enzymes in every nucleated cell of the body. There are SNPs, single nucleotide polymorphisms, associated with each one of these enzymes. And if we were to do genetic analyses of everyone in this room, the distribution of our SNPs for these enzymes would be all over the place. And that's relevant because we're giving you a drug which is highly dependent on the sensitivity of these enzymes for its therapeutic value and efficacy. And so dose escalation studies, in this one study, higher dosage was not always associated with greater efficacy, because if you up the dose orally, you may not be absorbing it. Can you stop methotrexate? We've already talked about that. We withdrew methotrexate before it was known how soon or if you would flare. We after about 6 months, we got identical appearing placebo methotrexate. And we randomized patients to continue to methotrexate or to get placebo. Turns out that everyone on placebo flared at 4 weeks. And then they were able to regain their therapeutic value. So what we do when we use it with pegloticase is we hold it here. It's probably in flux, but it's not a level of methotrexate polyglutamate, which impairs efficacy. This was the result of that double-blind study. Everyone flared. You have a patient who's stable on methotrexate who wants to get off methotrexate. You would like to get them off methotrexate. So we looked at every other week dosing, and this was published in A&R. Turns out in our study, every other week dosing, 52% of the patients were able to remain on every other week for 6 months. In a subsequent study, they did much better. 90% of the patients were able to remain on every other week. So of course you can lower the weekly dose. Consider every other week. But the problem with every other week is patients forget. All right, the rest of the lecture will be on toxicity. Here are the enzymes again. SNPs for all of these enzymes, and the patient doesn't come in with the SNP identities on their forehead. How do you predict how they're going to do with different doses? GI toxicity, nausea, stomatitis, diarrhea, vomiting, weight loss, all associated with rapidly turning over cells, highly susceptible to an antimetabolite. GI intolerance is the major reason for DCing. We give folate. Hopefully everyone gives folate. We can reduce the dose. Other toxicities, fatigue, flares, fever, nodules, associated with adenosine. There's 3 different adenosine receptors. One of them can give you nodules. Skin reactions. Remember that? Heme toxicity. Any exposure of rapidly turning over cells in the bone marrow, when it's given more frequently than it should be, will get you in trouble. I've seen legal cases in which I'm consulted. I never take a plaintiff's case. But the docs who get into trouble and are sued are the ones who give it more than once a week. Don't do it, please. Fetal abnormalities, we know all about this. We know about pharmacists unable to give methotrexate to young women of childbearing potential because of the craziness in our society. Lymphomas can occur on methotrexate associated with EBV. They're withdrawn and lymphomas melt away. Is this what we're going to do at 6 o'clock? Methotrexate in the liver. What's the best policy? Methotrexate and alcohol. Tell the patient it doesn't matter. Completely avoid alcohol. Caution about use of alcohol in excess, as there's no way to predict in advance how toxic it might be based on all those other enzymes I showed you. Perform regular monitoring of transaminase enzymes and albumin, and ask about alcohol if they are increased or albumin is decreased, or there's no interaction. This is eating up my time. Oh, that's good. I like it. Good answers. Don't completely avoid alcohol. It's probably not necessary. The early literature, why are we so worried? NI4's active pathological Scandinavia documented 26% incidence of cirrhosis. Cirrhosis. Now, these were Scandinavian psoriatics who drank too much, and they were also on arsenic. Curtis reviewed in, Jeff Curtis in Corona, and found that 1 to 2 drinks per day was associated with an odds ratio of an elevation in transaminases of roughly 2. So how much is safe? The variation is all over the place. We don't know. Make sure you know how much your patient is drinking, and if transaminases are elevated, then you really have to ask. All these different enzymes can affect what happens. Patients don't come in wearing different suits. And a white suit means I can take methotrexate with alcohol. Black suit means it doesn't. Just be careful. Because the phenotype, they all look like humans. Liver biopsies were recommended every 1.5 gram cumulative dose by dermatologists in 1980. We did these studies and we found any increase in AST, if it occurs in 6 of 12 measurements yearly, is bad news. This was the way we approach things was documented in a very large study. All the patients they found that our documenting was appropriate. There was one patient where they documented it didn't work, but that patient had type IDDM and 3B biopsies at baseline. 3B is bridging fibrosis. So don't allow your patients to drink. I think I've beaten this dead horse. Risk factors for elevated transaminases have been studied. Baseline elevations, untreated high cholesterol, pre-methotrexate LFT elevations. Be very careful in this setting, or not giving folate. We did a big study, which was a case control study, and we found that the risks associated with actual pulmonary toxicity, insulin-dependent diabetes mellitus, had the highest odds ratio. Not very well appreciated. Prior smokers, methotrexate pneumonitis is a hypersensitivity associated with the eosinophils in the interstitium. That means that you're likely to see it early on in the course. In fact, it always peaks between 6 and 12 months with a mean of 32 weeks. Patient with a dry, non-productive cough, pleuritis, be careful. Please do a baseline chest x-ray. If you don't, when the patient presents with cough or dyspnea, and you do imaging studies, you'll have nothing to compare it with. In a patient who is not dyspneic, but has a dry cough with pleuritis, you can lower the dose of the methotrexate, and in most cases, the patient will get better. If the patient doesn't get better, stop the drug. So complex and simple reasons. Methotrexate intolerance, use folate and give it sub-Q. You can give it orally 3 times in a 24-hour period, Monday morning, evening, and Tuesday morning. That's perfectly acceptable, and the dosage of methotrexate that is not absorbed is eliminated because you're giving less with each dose. How I use methotrexate. This is my last slide. Do use folate every day. The Europeans still don't give folate on the day that methotrexate is administered. No reason for that. It's not taken up via the RFC. Split the dose of oral methotrexate if you need to. I see the patient monthly for 3 months, establishing how they're going to do once they're on steady state, and then go to every 2 to 3 months. Start at this dose and move up. When you get to 15 milligrams, either split it or use it sub-Q. Don't do this stuff. Don't give it without methotrexate. Don't give it more than once a week. Don't ignore persistently elevated LFTs. What's an elevated LFT? It's not 2x. It's not 90. It's anything into the abnormal range. That's what we studied. Don't ignore a new dry cough. Don't DC the drug when starting a biologic agent. Why would you do that? And don't give up if the dosage is less than 20 milligrams and it's given sub-Q. I'm 4 minutes over. I'm a bad boy.